Todd, understandably a lot of questions about CRPS. I guess one of the first things to understand is can we predict who's going to get CRPS? You know, is there a patient profile, gender, age, menopausal state, kid, adult? Like is there any way of knowing beforehand who is at risk of CRPS? You know, like when you meet that patient and you're about to do an operation on them, any red flags in your head go off, I'm worried about this patient? Please use the microphone.
Can anyone hear that?
No, just pick it up. Pick it up.
Hands don't work.
It's the American way. All right.
I don't think that you probably should not differentiate. I think everyone can get it, so it's not really like you should only treat people that you're worried about, because it is a devastating thing to get. So if you can prevent it and take vitamin C, why not? But I would worry about it in people who have some sort of neurological compression, maybe, you know, like someone who has neck pathology or doing shoulder surgery, or, you know, probably smokers. I probably think those are maybe risky. What do you think, John?
Can I ask a question? My observation is it's more common in compensable injuries. Now, maybe I'm a cynic. But I think it is more common. Did you find any literature on that?
No. I mean, obviously, everyone says in workers' comp patients they do worse, and maybe that's true. That's obviously well studied, but yeah. But I've seen it in non-workers' comp, and I think...
Yes, no question you said it, but my observation is that you are more likely to see it in a compensable injury. Maybe I'm wrong.
No, John, there is some literature from WorkCover that does confirm that, so that is correct. But it doesn't seem to be based on gender, age, or anything else like that amongst the other population groups. So Todd, what do you do nowadays? Like, do you do anything different pre-operatively to try and prevent the CRPS?
Well, I do. I give
In
vitamin
fact, we'll
C.
go through all the panels. See if Quan or John does anything.
I mean, because it's probably relevant for Quan too. But vitamin C, it seems to be working. Mostly, they found that out with wrist fractures. So that's easy to do. Generally, my concepts for anyone who has a fracture that I see in the office or something is early motion, early weight bearing. So if someone who has an ankle sprain, I start them walking. I get them in a boot right away so they can do that, so that they start using their extremity. I think that helps, but I don't know. Anyone else?
Quan, what about you?
I think there are some people you just get a sense when they come in that they're going to be a higher risk of CRPS. I mean, someone who's had previous CRPS is going to be at risk. And then you've got those funny personality factors. You just get an inkling when they come in and they're blaming the whole world for their injury, rather than taking responsibility for what's happened and what they need to do.
That's the workers' comp patient.
Yeah, sort of that as well. But they just have a bit more of a tendency towards the CRPS. So the wrist fracture one was a study from probably about 10 years ago or 15 years ago that said vitamin C decreases your CRPS risk from 11% down to about 1%. So it did seem like a significant. I don't think that's been reproduced in other studies necessarily, but it doesn't harm. So that is a useful thing. I do talk to my anaesthetist to say, look, this patient I think is at higher risk. We have to be a little bit more on top of their pain relief early. Don't let them get into early pain. At the expense of perhaps some other things, like they might get more drowsy. We're always balancing the analgesia like that. And then get them to their physiotherapist early, get early motion, like Todd said.
John, anything different with the feet?
Explain it to them. I'm a dumb foot surgeon. I say to them, the nerves in your foot have gone crazy, right? They're telling you not to use your foot. You must use your foot. If you put your foot up in the air and say, my God, I can't use it, it's painful, you will never use your foot. You have to keep using it. They often say, am I doing more damage by using it? You're doing more damage by not using it. And if you explain that to them, I sort of rarely send people to pain clinics now, because you get a sniff that it's happening early, and you get onto it, and then you abort the course quite early. If they've been going 6 months, you're really going to struggle.
Yeah, and look, there is some evidence that multimodal analgesia makes a difference. So the vitamin C dose recommended as a minimum is 500 milligrams twice a day. with basically no side effects. I actually use 1,000 milligrams twice a day based on some studies out of the Mayo Clinic. And the other nice thing about that is when they're taking opioids which constipate them, the high-dose vitamin C acts as a slight laxative as well to counteract it, so then they don't need the Coloxal or the other stuff as well. There's also evidence that multimodal analgesia makes a difference. So if patients at high risk, they should be having a regional block at the same time. And there's also some evidence that a nerve injury, like a nerve compression post-op, so if someone's got ulnar nerve injury or some sort of nerve compression around there, releasing that nerve can actually break the CRPS pattern, but it's all very early studies. We don't really know that much about it. And there's also some work being done on gabapentin and Lyrica, but they have side effects, so we don't like to use them if we don't have to.
Just one thing to add what John said,
Yeah.
because I think it's true. People get afraid to use their extremity.
Yes.
And I often like to get an early MRI, just that way I can show them, look, there's nothing else going on here. So just early investigations, I think, are helpful.
Yeah. And bone scan blood flow patterns can also show you when the CRPS is happening, but I think these days we're so good at picking it clinically, we don't need the bone scan to be able to make the diagnosis.
But like, I guess more importantly, that you don't have a fracture,
Yeah.
you don't have something else, you're not going to damage your foot by
Agreed.
using it.
Kwan, if a patient's on blood thinners, can you still do your local anaesthetic surgery? You know, someone, I mean, as simple as aspirin or as complex as warfarin, can you still do that?
Yeah, I think I got your question. The sound guy, can you put a little bit of that microphone into the wedge foldback? There's no foldback coming through from that, so it's a bit hard to hear the questions. So I think the question was, can we do anticoagulants? No, can we do Wayland on anticoagulants, including warfarin, yeah?
If someone has blood thinners, can you still do the procedure?
Okay, sorry. So I've only got,
Sorry.
I've got a funny ear. So yeah, you can. So in fact, for hand surgery, there has been studies coming through. You basically don't have to stop anything. They can be on Plavix, they can be on aspirin, they can be on warfarin, as long as their INR is less than 3. Not that many people are on warfarin anymore nowadays, but yeah, it really doesn't make any difference for hand surgery. Push on and do it. Whether that's Wayland or not, in fact, any hand surgery.
Okay, thanks. John, shifting to you, indications for surgical or non-surgical treatment for Achilles tendon rupture, athleoid, athlete, who do you operate on, who don't you operate on?
That's an hour question. All right, so very quickly, you explained to the patient that there's a vogue currently in Sydney to manage these non-surgically. The non-surgical management, we believe, is longer, requires a more compliant patient, has a slower return to sport, and has a slightly higher risk of re-rupture. So in general, if they want to get better more quickly, if they want to return to sport more quickly, with a lower incidence of re-rupture, we offer them surgery. That's a sort of the one-line answer.
All right, well, sticking with you, John, how important is it for you to have a big toe?
That's a wonderful question. Okay, so, and the reason, well, that's a good question. So everybody thinks you need a big toe, okay, for balance and to get in your shoes and run and all that kind of stuff. Roger Mann is the cleverest bloke in foot surgery in the last 40, 50 years, said, well, do you really need a big toe? So he went off to the microsurgery clinic where they take off the big toe and they do a toe-to-thumb transplant on these poor buggers that have lost their thumb in a sawmilling accident. And he found 15 of these poor buggers that had had their big toe taken off at the MTP joint, expecting to show they had trouble with balance and shoes and all these things that we spoke about earlier. And he found, you know what, they were all fine. They could all walk, none of them used fillers in their shoes, none of them had any trouble with balance. The only trouble they had was with running, you see. So you don't actually need a big toe, isn't that interesting?
Kwan, can you hear me? Okay. How big can you actually go with your awake surgery? I mean, I know a couple of my colleagues over in the UK are doing awake shoulder surgery with regional blocks, and they're doing arthroscopic cuffs, etc. But that's not with local infiltration, that's with a regional block and some sedation. How big are you looking at? Are you going to do a joint replacement under local anaesthetic?
Yeah, so there is a difference between what I'm talking about and regional blocks. So regional blocks is something that my anaesthetist will do as well. That's blocking the nerves as they come past the neck and into the shoulder. So the whole arm is asleep. There's no motor control, there's no sensory control. So you can't do some of what I was saying there under a regional block. You can't get the patient to move, for example. And you still need a tourniquet because there's no blood vessel control. So Wayland is more about eliminating the tourniquet, still allowing the motor side of things. Yeah, you can do joint replacements. You can do joint replacements on the fingers, so MCP joints and PIP joints, DIP joints we don't replace, we fuse them. Trapeziectomies, Dr. Lalonde has talked a lot about doing trapeziectomies under Wayland. It's not something I've been game to try yet, but it is out there and being done by someone somewhere.
Now, Todd, as a surgeon, giving a non-surgical talk like CRPS, I have to say, is incredibly brave at the risk of having everyone's CRPS sent to you. If you've got any CRPS, please don't send them to me because Todd's the expert. But Todd, is there actually any surgical treatment for CRPS?
Yeah, so there are...
Just speak to the mic and speak to the audience, please.
There are studies that look at amputation for patients who have intractable CRPS. They have terrible pain and they can't go on. And, some studies show that's quite effective. I've never done that myself. John, have you ever even considered it?
No. While I was working at North Shore, there was a registrar. They had a young girl who had a scratch on her arm and got a CRPS. And basically her arm was stuck in that position for about 5 years. And she couldn't wash her armpit or anything like that. So at that time, it was suggested they take off her arm there to keep her axilla clean. But that's the extreme example.
So, but that's pretty much it. There aren't really any nerve procedures or anything else, just things on amputation.
So there is a lady named Annie Oaklander in the US who's a microvascular surgeon, and she's doing some studies now on nerve releases as the cause of the CRPS. And I went to a lecture that she gave where she was talking about specific localization of the pain, of trying to get the patient, rather than talk about everywhere of the pain, trying to actually find one spot only. And if they can point to one specific spot of where the pain's coming from, which is rare amongst these CRPS patients, she says that if you release that particular nerve at that particular location, it's often curative for the CRPS. So it is interesting that there are studies out there happening.
Is that Susan McKinnon?
Sorry?
McKinnon you're talking about? Susan McKinnon?
I think they're at the same centre.
Yeah. So there is a theory, I think if it is that microsurgeon, she does talks on that, saying that there's no true CRPS in the hand, and she thinks they're all related to a nerve compression somewhere. You've just got to find it. Whether that's a median nerve at the wrist, median nerve at the pronator, median nerve at the lacertus, or perhaps a cubital tunnel. I'm not sure that's a widely held belief yet, because I think we do see patients with true CRPS, but you certainly do need to rule out a nerve compression. I think that's really important to do.
Yeah, like that's the danger. See, don't give the diagnosis without excluding everything else. Don't give the diagnosis without excluding everything else. That's important, right? Because if there is a nerve compressed and you miss that and say, oh, it's CRPS, well, you're not doing the patient any good.
And Todd, is there a difference between post-operative CRPS and CRPS from just a minor injury, that person that twisted their ankle, versus the patient that had a traumatic cuff tear and had that repaired? Is CRPS the same in both those situations?
Well, there's probably more likely to have CRPS2 from surgery because you've damaged a nerve. And the symptoms and treatment are the same, so I don't think that makes a huge difference unless you're trying to figure out if there is some nerve irritated. But generally, I don't think that anyone can say that it's the same or different. There's just not enough studies out there, and everyone presents so differently. So it's hard to know.
I have a question for Quan. Do you clean up the rubbish like that other surgeon does?
Do you throw out the rubbish just like the other surgeon does?
So Quan, in all seriousness, do you always have an anaesthetist available when you do that?
No, I don't have an anaesthetist available. So I actually talk to the patient beforehand, and if it's a Wayland suitable procedure, I'll give them the option. And a lot of this is you judge the patient at a time. Is this someone who you think is going to manage it or not? And often I'll put to them, maybe we can have an anaesthetist on standby just to sedation if they look like they're going to be a bit nervous. But no, one of the cost savings is that they don't have to pay that anaesthetic fee. And that makes a bigger difference, of course, for the uninsured patients who are already paying a lot to actually get to the hospital in the first place. That the patient does need to know. That means that if they're going to be nervous during the procedure, there's no backup for sedation there. Okay, so pick the patient well.
All right, thank you. John, is there any association between the sesamoid stuff that you were talking about and Morton's neuromas? Like, are they completely different diagnosis? Is there overlap? Do you do nerve release surgery at the same time as you're dealing with these?
No, not usually. I think they're two separate issues, I think.
Two separate issues?
I think so, yeah.
Okay, very good. Look, we've got a whole bunch of questions, but we're out of time for this panel. So I'd like to thank all the speakers for their lectures. They will all